district. We run a few different statewide initiatives, one of which is why Kristen and I were able to meet, which is the Alliance to End for a Hunger-Free New York. So they work a lot on food insecurity overall, and then my work is more specific to food as medicine. So working with a lot of different stakeholders across healthcare and government and policy implementation, and providers, individuals who are served by these programs. So we try to convene everyone and then are doing long-term change and hopefully healthcare overall in the integration of nutrition. And I know that Kristen had said it would be helpful to quite a few folks to learn kind of the baseline of food as medicine and to really build out where to begin a little bit. And I know that you have some produce prescription programs in the area, but um, yeah, if you are interested in other levels, I've included kind of a range of what to prepare for, and then I'm here for questions after, or we'll share my email as well in case you want to reach out and be part of our coalition, either one. And then, yeah, can connect if you're looking to scale up at a later point as well. But I intended to say all that during this beautiful slide of Swiss chard. My apologies. But really wanted to begin with all the areas in which you can think about approaching food and nutrition security, because really there's a range of drivers. So creative solutions is a big part of food as medicine, since it's so multivariable with the social determinants of health and what are really driving the issues in both like the direct to consumer access and our food systems overall. So there's really an arrangement of factors that you're going to want to consider and like understand about the population you're aiming to serve ideally. And a lot of ways to creatively link into what might be going on in the food system around you, whether that be connecting to farmers, for example, to glean and get healthier produce to these individuals, or for diversifying something like Double Up Food Bucks to individuals that are also part of the local food system, etc. There's a lot of different creative solutions around all of these different reasons why people are in this boat. So I just wanted to start a little more generally, because it can take many different angles, and coordinating amongst multiple programs can really be in your favor on how to appeal to a group, and including nutrition education, for example, can definitely be a big component in helping to make a larger change for behavior and also hopefully health of the population for which you are aiming to serve. And I think you got to see this last time, but it's always good to sort of set with this one in particular, because food as medicine is sort of niche, and then at the same time, all of food access is it as well. Improving nutrition is really multi-angled. So population health programs on the lower level are much more about prevention and working in food insecurity in the first place so that diseases are not advancing further. So SNAP and WIC, although some people argue that WIC is really much more of a produce prescription program, can be viewed that way. It's particular in influencing healthier food access specifically for folks. And then healthy initiatives programs are another, where it's like a $2 amplification of access to fruits and vegetables at a farmer's market. And then looking more at there's a broad range of population level health programs that also apply. A lot of these are more within the Farm Bill overall. So if you're in any arena of advocacy, um, pushing your state representatives to really support this and continue to expand access to SNAP and farmers market nutrition programs, commodity programs, and beyond can be a big part of that with population level work. And then produce prescription kind of advances up further into populations that are already having struggles, not just with food insecurity, but with disease types. Most of the time, they're more specific to someone that might be experiencing pre-diabetic blood sugars, for example, or hypertension. So they're already starting to sort of need more medicines or healthcare engagement. And so giving them the foods that would help to mitigate that increasing risk level is a big part of produce prescriptions. And then Next is like treatment amplifies, medically tailored food packages. They all have a bunch of titles too, which makes it a little fun right now because yeah, medically tailored groceries versus food pharmacy versus a healthy food box. All of them sort of overlap right now in these brackets too, but sometimes they're pre-processed to help folks that have bursitis, for example, or arthritis, or need to have a heavier dose of intervention. So a produce prescription is really like offering supplemental. Groceries go more into trying to source a range of foods that are healthier so that they can, or having them pre-cut so they are more utilizable as well. So next level of like health conditions and then also pressures that they might need a more intensive intervention for. And then medically tailored meal programs are when you're very ill and unable to cook for yourself at home. So whether that be you're going through cancer treatments, for example, or dialysis, something that's more intensive, taking up a lot of time, or you don't have the capacity to physically prepare meals at home for yourself, age, ability, etc. That is when these sort of kick in further, and they do have different kind of markers that you're looking for to influence in each of these levels as well, and whether that be like healthcare utilization and specifically, or what they might be doing for your blood pressure, what they might be doing for your A1C. So they all kind of fall into different arenas, but that can be really helpful to know and understand. And then I wanted to show you a little bit of a proof on how this is usually working in the healthcare system. And I'll reflect on, I know you had an 11 and 15 waiver focus last time, so it is pretty similar to what usually is happening across the states, but more than often than not, right now, the clinic is the entity that does a screening tool. In New York with our 11 and 15 waiver. It can come from multiple areas now. As a community-based organization, you would be able to screen patients if you are contracted within social care networks to do so. But managed care also does these screenings sometimes. So in our situation with some of the policy that's recently passed in New York, it's good to know that you could potentially be reimbursed for this portion, and it can come from multiple parts of the healthcare system at this point. So it's good to know that it could be multiple arenas that you might be involved with if you're getting to work in this field via the 11 and 15 waiver. So once people are identified, they're really going into the electronic health records and figuring out, in our case, in New York City with the 11 and 15 waiver, which level of those interventions they could use application for, whether it be the meals program, home delivered meals, or clinically appropriate as they've switched it to. And then the prescription program, groceries specific, or if it's pantry stocking, nutrition education, transportation to receive the food items in particular amongst the populations that are qualified. And then oftentimes healthcare is linked via a variety of ways to these programs. Sometimes they are located within the clinic itself, and sort of amplifying, I would say, across the state now and nationally. There's more of that going on, especially with Feeding America funds have started to shift that a little bit to be more prevalent. And then there's also times when it's a mobile intervention that can be really handy for your more rural populations, for example, or those that if there's pockets of health disparities that you're already focused on within your area, a way to bring it to folks that have like fewer resources and need access to transportation as part of it. Or, it's also coming to the pantry and getting the referral via them and building its way through it. But beyond just short-term things, like really, healthcare has been diversifying. It's taking a long time to get further along. But there are a lot of different plans now that do have either contracts directly with community-based organizations to provide something like meals and prescriptions, or you're more within their charity route, for example. But there is potential to be paid via risk arrangements and value-based payment arrangements that allow you to reap the benefits of serving a certain amount of folks who they identify, but also potentially having the cost savings associated with their reduction in healthcare utilization also benefit your program. It's a matter of like knowing that piece for integrating into your contract overall, and kind of diversifying how you could be paid with certain populations. So there's a lot of nuance to it, as you might be picking up on, but quite a bit of work is going on overall. So then just wanted to help clarify like what each grouping is in the broader base of like national context, because produce prescriptions, as I mentioned, it's much more towards a preventative service still. Like they have diet-related health risks and conditions. Food insecurity is definitely a part of what they are experiencing and likely amplifying their need for care. And then really it's going towards nutritious foods overall. These are typically either in a grocery setting, in a farmer's market setting, or in sometimes people are pulling them off on pantries or farm. Like I have seen them function even in farm stands that are alongside the road. That's possible too. But yeah, they're really trying to amplify their access overall. And if you aren't familiar with some of the national movements, really this is from the National Produce Prescription Collaborative. They've been working with groups across the nation, so they're a really good group to join if you have a particular interest in this and want to take part in the broader scale implementation of it. And GusNIP is another. You can actually go to, which is Gretchen Swanson, also oversees all of this evaluation of these programs on the Nutrition Incentive Hub. That is publicly available information. You can go to their website and actually look at projects and see what the typical range of incentives are across the nation. I recently did this work and it was a little bit shocking to see like what level people can, what's normal right now. Because I looked at nearly 50, so I did 47 program reviews from their website and saw that only 8% were around $40 a month. And then $5 to $10 was around like 23%, 10 to 20 was 24%. And then the majority, your 46 or whatever percent was more between 20 to 30 in that range. So they're kind of relatively small right now, and it can be tough to sort of balance the access piece versus what a return on investment for healthcare would look like. So I just did some level setting recently to try and get a better grasp of that in particular. And I'm very much an advocate for like the more access people can have, the more impact you will have. But also think that there's a lot of financial drivers that influence how much we can really ask for in healthcare and what that means overall. But it's a great place to look for other examples of what people are doing across the nation, and has quite a bit of content on understanding other ways to measure what these programs might be doing as well. And then just wanted to throw in some farmers market based programs that I've been a part of before. So yeah, it can be really complex to even just do this work. Like on the ground, you have to have your farmers involved and okay, and have a system to track like where the funding's coming from, whether it be like bags at each one, and then the tokens that go along with it, or the different vouchers that go along with it. And the reimbursement structure can be pretty intricate, especially there's been times when I've worked with programs that have done 3 at one time. And so keeping track of like how much they're getting and what's applicable to each group, and having all these players when you're dealing with like a 60-person farmers market is a heavy lift to navigate. But yeah, if you're interested in tools on that or further discussion about that, happy to meet with folks as well. But it can be really nice to see the farmers market angle go into play. And again, they're doing this in other places across the nation with cards now too, and linking it more to grocers. So there's also a more traditional food system approach that does include this model too. And then specific to medically tailored groceries, This is, again, a little bit further up. You're doing light processing potentially. I can say from personal experience, something that we had done was actually employ adults with developmental disabilities that had previously been volunteering with the program that I worked with, to pre-process food items, set up the boxes themselves. And actually, it was a really neat social aspect and a way to have a workforce to do this work as a community-based organization. So again, diversifying who you have as players and how you can make this more accessible to the folks that you are serving. There's a lot of creative ways to do that and to make a bigger impact in like your society, community overall. Um, but yeah, you're really sourcing quite a bit more than just produce for these. You're looking at having whole grains be a part, or healthy proteins like beans, or having low-fat dairy or other items that are specific to the disease type that you are serving. And that does take having a little more nutrition-specific knowledge as well. It's not required for this level to have a registered dietitian, but it's always good to have a really strong grasp on what am I working in and what is the research behind what will help this particular condition. And then also including things like spices and education, recipe books, um, if you can, like a culinary medicine side where you're actually showing people how to cook, whether it be online to simplify access again, or in person to try and influence more aid to build a community around it and excitement around it and socialization as a support tool. That can be really a great thing to include. And then something that I've also really tried to emphasize before was ensuring that they have the culinary tools to do this work at home, because a lot of people don't have, um, like the proper knife or like a peeler, or if a mandolin is a lot simpler for someone who's older and having mobility issues. That can get a little tangled when it comes to working with clinical sites as well, because they're like, we don't want to give that out. It's a liability. But knowing who in your community you could affordably source these other items to support their access to it can be a major change in what they're going to have available. And then also knowing, like, again, budgetary limitations exist in all of this. So a different strategy that I have employed before is to have food resource lists based on which area people might be living, whether it be by zip code or county. So making them aware, like if you need more supplemental food, if this is not enough, you could go to this food pantry, you could qualify for WIC via this agency or farmers market nutrition coupons, really laying it out so that they can diversify, have healthier food access, be as constructive and like multi-supported as possible. And I'm trying to think if there's other things to really emphasize within it. Something else that we had done that made this more effective was also having a registered dietitian at when I'd created programs along this line myself before. We were in a clinic, so it helped to have Medicaid transportation be a reimbursable part of the program, so people could get direct nutrition therapy, and then also have transportation be a reimbursable service to get this too. So not light lifts, and they don't all have to include all those pieces, but I think the more strategic you can be, the more effective the work overall. And then, yeah, so this was in clinic directly, own experience again. I had worked with farms over, well, 12 local farms, and then it was a very heavy dose on local produce that, and introduced quite a range of foods. It was like over 120 particular fresh fruits and vegetables. And then we were able to support, the food budget was 74% locally sourced, which was really exciting to me. And so that was around, we had a $78,000 budget for 9 months. So quite a bit went into local foods in particular, and then really diversified what people could have access to overall. And really getting to try new foods had been some of their favorite pieces of that program as well, and just the direct interaction that people had. They really valued that. extra level of care. And it's something that you can explain further to who funds it, in order to afford it and keep it rolling. And then that it would be helpful to sort of have the comparisons again. So these layouts of like how much they are, and then, medically tailored groceries being partial or near complete nutrition, not total. And medically tailored meals are, yeah, nearly complete. You're feeding them, it's already laid out. They either are delivered on a regular basis so that they're already warm, or that they're frozen and can be pulled out and utilized as needed, but they're much more nutritionally calibrated. Um, and then just to give you another example of a workflow, so this is God's Love We Deliver from down in the city. They're one of the agencies that have had a lot of success in directly engaging healthcare, but they've also existed since the 1980s. They were born out of the HIV and AIDS epidemic, but this is another sample of how they move through, how they transfer patients to their programs in particular. Let you look through that later. And then how they make their case for costs. So again, medically tailored meals is one that's an extra level because you're doing registered dietitian oversight, medical nutrition therapy, usually other services, and they're delivered to the home. So currently in New York State, for example, these are paid for via like in lieu of services or direct contracts. And right now they're like $9.50 a meal with in lieu of services. So $7 to $10 a meal for a heavier dose with having delivery be a part of it is the usual. But it's a pretty encouraging model, considering that if we were to, some recent projections from a researcher named Kurt Hagar included that if we were able to serve as many people as were eligible for these meals, it would save us up to 38.7 billion annually across the states, which is a phenomenal number. And this is really calibrated to avoiding like skilled nursing facility, long-term care, hospitalizations that could have been potentially, avoided, and also ER visits. So a lot of those tie into that number in particular. But yeah, I think I'm already probably chatting a little. I'm at 12:30 already, but wanted to sort of also just lay bare like what still needs to happen in this field overall to understand it further and what's helpful. So just what the cost is. That's usually the case that you're pitching to healthcare. And then a little bit more about what the gaps in understanding still are. And there is a lot of work to be done on all of these arenas, I would say. There's more research in medically tailored meals and produce prescriptions that's building up still. But there's a lot to say for not knowing what the dose response is, in particular, what people need for the time frames, in particular, when you can intervene on a disease type and make the most difference. There's a lot to say for like what we're still learning, and even with food types and genomics and how much that can influence someone's health, because it is so unique with nutrition. There's a lot more to learn right now, but and then the other things to be aware of in turning over into healthcare is like HIPAA compliance is a huge part of approaching and safely being able to participate. The decreases in utilization that I mentioned are something that you want to ideally be able to track. So the healthcare, both preventative attendance, so say getting them to well care visits or having medication adherence. There's different ways to track that creatively, reducing their hospitalization, readmissions, ER visits, skilled nursing facilities, what we already mentioned, and then the biomarkers. If you can measure A1C levels and blood pressure and BMI or lipid panel like LDL, that's all in your favor. And then really making the case for like, this is what I can save if you invest this. There's a lot of, again, tools to use and lean on that show that. And then same for scores in healthcare and engagement. So they do want to, like, for example, with Medicare, show that people enjoy taking part of this. They enjoy being part of this plan. So having Medicare stars be a part of it, that is a more advanced level of the work, but that can really also play in your favor. And then I'll stop there because it's a lot to spit out quickly and probably overdid it. So let me know what I can help respond to.